Good afternoon, good evening. Thank you once again to the Royal College of Physicians for inviting me to deliver this short lecture, and to the Ceylon College of Physicians for nominating my name. Let me first begin by sharing the screen and putting up my slides. The topic I hope to discuss is health inequalities and clinical practice. Lessons from a Sri Lankan montage. And during the next few minutes, I hope to take you through a clinical scenario and try to describe a montage of health inequalities related to that scenario, then try to trace roots of these inequalities. In a sense, it's a hypothesis, and then tease out a few lessons for clinicians. So this is the case scenario. So it's a 55-year-old. I will allow you to read. So she's considered to be from the Indian Tamil community, though she's a Sri Lankan, having all the rights of a Sri Lankan officially. Her home is in a tea plantation in an area called Hatton, and she has presented with severe anemia. And the only cause found after doing the investigations was that she had iron deficiency anemia. There was no bleeding GIT or from anywhere else, but she had multiple ova of helminths. So the assumption was that it was the ova, the helminths, which is causing the anemia. So if you look at this population, even recent studies have shown that tea plantation community does have a high prevalence of anemia. Now let's look at the inequalities which we see in relation to these clinical presentation. If you look at the status of populations in relation to anemia, you find that the prevalence is high in the plantations compared to other sectors. Now, plantations form a fairly distinct group. That is, these are historically have been mainly tea or rubber plantations, and it consists mainly of workers who were brought in as labor from India. They are relatively captive and relatively isolated in those plantations. They live in the plantations, most of them, and they do not integrate much with the rest of the population because everything is found almost in those villages and within those areas, and it's a deprived community. So you find you're able to get data from these areas, and you find that the rates of severe anemia as well as moderately severe anemia is much higher in the plantations, sometimes 10 times higher. Severe anemia is 10 times higher in the plantations compared to, for rural areas. This is from the Demographic and Health Survey. So immediately you see that this is something which needs further exploration. And if you look at the prevalence of soil-transmitted helminths, again, you find that the plantation communities have almost 9 times more prevalence rates than the national average. And that's, again, the gross inequalities which we see between the plantation communities and other areas of the country. Now, there's a long history of these of soil-transmitted helminths. So, and these inequalities have been there even before. In 1888 were the first reports of hookworm in plantations. By 1897, the majority of deaths from hookworm infestation was in the plantation workers. And in 1909, almost 90% were affected by helminths. And in 1996, still almost 90% had at least one type of soil transmitted helminth. So this shows an environment which is allowing this soil transmitted helminths to be prevalent, and behavioral patterns which are keeping the infestations going. In 1994, the government began a biannual mass deworming with mebendazole 500 milligrams. It was continued up to 2005. There was no deworming from 2005 to 2009, but the prevalence bounced back to 29% in children. So it seems that though the rates had come down compared to what was there in the 1990s, this was still a significant cause for morbidity. And if you look at the overall prevalence was 29% of school children. But if you look at the prevalence, you find in those 5 districts, Nuwara, Ratnapura, Kagala, Kandy, and Badulla, you find that's in the center part of the country, central part, you find that there are pockets of high prevalence. And there are other areas which have less than 20, that's the blue areas. Above 50% is the areas which are shown in red. So in these areas, you find again inequalities in the geographic distribution of the helminths. Now, this persists, and this is a study on your right, which was reported in Lancet Global Health in 2019, and you still find those areas affected, and that's the central area of the country, and you find that the central area of the country have 20 to 40%, that's a blue area, compared to the yellow area, which is less than 1%. And there's a gradation of these inequality of the prevalence. So there seems to be something which is happening in these areas, and researchers have identified these reasons. Geographic factors, because it's in the hill country, moist, and the soil factors all promoting the transmission. Congested living, because people in the estates and plantations, they live in what they call lines. That is, the houses are in a line of units which are attached, and they had, so as a result it's congested. And then you have poor sanitary conditions. There is lack of safe water, and toilets are shared often, and the habits also, they have poor hygiene, partly related to the low education level. So you have low maternal education levels, poor hygiene also. So these are some of the factors which have been identified by researchers as reasons for the inequalities in soil transmitted helminths. But let's look at this in broader terms and explore some of the other social and health inequalities. And you find that these areas are clustering several disadvantages, or several, they illustrate other areas which seem to be of high prevalence. So if you look at the socioeconomic status, they are poor. So above, if you look at the households, 71% in the plantations are in that lowest quintile, national lowest quintile of income. Then the access to drinking water is almost half that of the national average. The the sanitation facilities have certainly not improved to the extent of the national average. And the majority seem to be living in these congested lined rooms. Those are, as I mentioned, I'll show you a picture of that in the next slide. And these are individual houses. They are partitioned, they are separate, but they are in one line. And you see the Hindu Kovil here. So most of them are Hindus, and you can see some of them have toilets outside, right? So here also there are toilets. This is probably common toilets which they have. So you find that it's a very congested environment that these people live in. Utilization of services, again, is less. So even though Sri Lanka has education free at the point of delivery, the plantations have the highest levels of rates of females who don't have education, almost 3 times the national average. And our health service, which again is free at the point of delivery, also shows inequalities. Even though the rates overall are low, the utilization of deliveries, facilities in institutions is less in the plantations. Undernutrition, again, is higher. Low birth weight is almost 25% compared to the national average of 15.7. And childhood malnutrition, whether underweight or stunting, is again significantly higher in the plantations. And female BMI in the reproductive age groups of 15 to 49 is almost double, more than double compared to the national average. It's 22% compared to 9.1% in the national average. And if you look at domestic violence, again, the prevalence of ever abused is 31% in Colombo, almost 50% in the tea plantations. Currently being abused, 10% in the Colombo district, 25% in the tea plantations. I know these are relatively high figures for any country, and but you see the inequalities even in a situation like domestic violence. So if you try to string all these together, you can look at them as a life course of inequalities. So this montage actually feeds into each other, and you can see how they get disadvantaged and they have gross inequalities as they grow older. So at the beginning, lower birth weight and poorer nutrition because of poverty, as well as environmental factors and helminthiasis. This would lead to slower mental growth, and they are exposed anyway to lower quality schools compared to other areas, and as a result, these compounding factors would lead to lower education levels. Now, if you have lower education levels, you are unable to get out of the poverty-ridden environment. You revert back to working in the informal sector or working in the plantations, and there you have less access to healthcare, you earn less, your nutrition is poorer, and you're exposed to a lot of physical hazards, exposure, injuries, and so on. And as a result, they have poorer health and higher morbidity rates. And in our patient, all these would have worked, and they would lead to the higher risk of developing of worm infestations as well as anemia. So it's a montage of inequalities, and you are getting accumulative insults affecting their health. So what could be the roots of these inequalities? So in the next few slides, it's more of a hypothesis. I'm trying to look at the uh, historical reasons which could explain this population's health issues. So let's look at their origins. See, all of them were brought in by the British colonial tea planters. They were brought from the lowest caste in India, and it was forced migration. And once they came, they were a population in captivity, living under appalling conditions. There was gross, overt, explicit discrimination based on racism and white supremacist ideas. And post-independence, the integration was slow. And in fact, there were issues of governance because they were disenfranchised for a period. And some of this is documented in this book, Bitter Berry Bondage. And if you get the chance, you should read that. This is about the coffee workers. So it was forced migration, and they came in waves. Europe is concerned about the migration which happens periodically, but you can imagine the resentment of a local population where forced migrants are brought, who are kept separate, but they take over your land. The most fertile virgin land is taken over, and they are working in those areas. So the resentment is deep-seated as a result, but it's much, much less now. But you do have that, discrimination. And at the beginning, there were, in 1911, the census showed 500,000 immigrant workers in more than 1,900 plantations, scattered mainly in the hill country for tea, but in other areas also, Western and Sabaragamuwa, in those areas with rubber. Okay. So they were a population in captivity, and you can see the relationship of the farmers, of the planters, and you can see from their body language the dominance which they show, and these are the subservient workers, and they were from the lower strata. And when they came here, the Kankanis who controlled them were from a higher caste, and in fact they were in debt to the Kankani. So your work was trying to repay the debt. And the justification was that the conditions not any better in India. So there were willing recruits, and they were kept in the plantations where they had these lines which were built, right? And they lived in those quarters, and those were appalling living conditions. Even though they provided housing and healthcare, the latrines, in fact, were not provided for in a majority. And the reason given was they would not use them, even if they were built. So which means they used the surrounding areas for defecation and so on. So you can imagine why there was a very high rate of these helminths right up to 1990s. But now with integration, things have changed and the rates are coming down. And as I mentioned, the discrimination and stark inequalities were there all over. So that's even now you find the lines which people live in, and that's where the plantation managers would live. And this was coupled with the white supremacist ideologies of treating these people as inferior. Now, post-independence, Britain was asked to take back these workers whom they brought, but they refused. So they refused to grant citizenship. India declined to repatriate all of them. And Ceylon, independence in 1948, came up with the Citizenship Act, and they lost the franchise, the right to vote. You must know that Sri Lanka had the adult franchise from 1931 or so. They were known as stateless, and this was a term used by India, coined by India, to add diplomatic pressure on the newly independent Ceylon. After a lot of struggle, they regained their franchise only in 1964, and it is reflected in this graph where the plantations, the IMR is it's much higher than in other areas. So there is a rapid decline in the infant mortality rates post-independence in Sri Lanka, but there is a lag in the plantation sector until they started to decline from somewhere in 1970s. And that's because of progressive steps which are taken, citizenship being granted, political representation, and there was Mr. Arumugam Thondaman, a legend in the area, who fought for the rights of the Indian Tamil community. They had minimum wages, and the health services and education started to diffuse into those plantations, and people began to access. Now we do have even doctors who are coming out from that those areas, and infrastructure was improved. The nutrition was being tackled with the MCH, the maternal and child health, as well as supplementation of pregnant mothers. And more recently, they've come up with a new act to form a new Villagers Development Authority for the plantation regions. So this just show you improvements in housing conditions. The houses themselves, the lines themselves were improved, plus they were clustered as villages in certain areas. And as a result, we find that the inequalities are narrowing, and there is a rapid decline in the inequalities of, for example, the infant mortality rates. So what are the lessons for clinicians? If you meet a patient and you know all these facts or all these other inequalities and deprivations which are happening. So you have to realize that the clinical presentation is due to cumulative insights. You're having a person whose whole life has been one of deprivation, and treating with simple iron tablets in this instance and mebendazole might not give a permanent solution to her health status, though it would improve her anemia. And also, not only were there cumulative insults, but this is based on some of the role played by colonization, which helped to generate such deprivation. So your narrative should probably be rephrased, right? And this shows the low motivation, the poor levels of education, the congested living, the domestic violence, and in desperation coming to work in a house as a domestic help. And that narrative is probably related to generations of discrimination and exploitation, which began in that community during the colonial period. So when you are treating this patient, you have to know this background and realize the montage of inequalities that this patient is a victim of. So this brings out the third point, and that is that we should be looking for other blind spots in Sri Lanka. There could be other inequalities in health inequalities based on ethnicity. Now, we know that obesity rates and even diabetes rates are higher in the Muslim community. But are there any other areas which we need to explore? Is there religious discrimination and religion playing a role in differential disparities in health? Is there discrimination against the rural population in these rapidly urbanizing and westernizing countries, such as Sri Lanka? And is there language discrimination? Now, we have done some work to look at the different facets of language discrimination. Very simple example, the mere fact that most drug labels available in pharmacies are only in English. And we have to go to Supreme Court to try and change this. And there's resistance even to change such a simple and obviously justified action. That is to include labels in Sinhala, Tamil, and English. So if you are thinking of advocacy as a medical profession, as a clinician, we should be supporting pro-health services, that is investing in infrastructure in these poorer areas. We should also look at the other social determinants, promoting education, minimum wage, better housing. We have to widen the social safety net. And you saw this patient came because of the poverty and wanting to support the family. And now we have them leaving to various countries as migrant workers, especially from the plantations. And these we should be advocating for national integration at a faster rate. And we have to counter discrimination. It should be zero tolerance to discriminating against any of the ethnic groups. And also, this example highlights that we have to address coloniality. Now, coloniality has come into focus as a contributing factor for health inequalities, especially after George Floyd's murder. So you're finding a lot of literature showing how the present day inequalities, especially between whites and blacks in America, is rooted in racism, which happened at several decades or centuries ago. And that's an interesting area which we also should be looking at. This is the definition of coloniality, that is the patterns of power that emerged as a result of colonialism. So you have that pattern still being continued of dominant planters and a subservient group of people who are workers. So in summary, I have tried to tease out a few lessons from this case. And firstly, that these clinical presentations emerge from a montage of social inequalities. And the roots of these relate to discrimination, colonization, racism, and social exclusion. So when we see such patients, we should consciously consider rephrasing our narrative. And we should be researching more into these inequalities and become advocates to narrow inequalities. Thank you very much once again for your patient listening. And once again, my thanks to the Royal College and the Ceylon College of Physicians for inviting me to deliver this short presentation.